Hi, my name is Kathy Kinnett. I'm Vice President of Clinical Care for Parent Project Muscular Dystrophy. Welcome to the second of PPMD series of 3 pulmonary webinars, Duchenne Pulmonary Care for Tweens and Teens. Just as a little bit of housekeeping, this webinar will last for approximately 60 minutes. All audience members are on mute, and you can type in your questions in the box in the lower left-hand side of your screen. If it's possible, we're going to try to save the questions for the end of the webinar. In this webinar, as well as the questions and answers, will be archived on the PPMD website. Before we begin, I would like to just mention Duchenne Connect. As you all probably know, Duchenne Connect is an online patient-reported registry supported by PPMD. If you've not registered, please do. And if you have registered, please be sure and update you and your child's information at least annually. The data, as you know, collected in Duchenne Connect is used by clinicians and researchers to inform clinical trials and speed research. And in addition, the data that we collect helps to determine optimal comprehensive Duchenne care and to identify gaps that exist in the areas of care and education. The websites for Duchenne Connect are on the PPMD website, www.duchenneconnect.org, or you can email the coordinators at coordinator@duchenneconnect.org. It's my pleasure now to introduce today's presenters. Dr. Jonathan Finder is a professor of pediatrics at the University of Pittsburgh School of Medicine and an attending pulmonologist at Children's Hospital of Pittsburgh. He's worked closely with PPMD since 1999 and was the first author of the 2004 American Thoracic Society's consensus guideline paper on respiratory care of patients with muscular dystrophy. He's published many papers on this subject since and remains closely and actively involved in the care of patients with neuromuscular disorders, both in Pittsburgh and internationally. Dr. Oren Kupfer is an assistant professor of pediatrics at the University of Colorado School of Medicine and Children's Hospital, Colorado. He completed his pediatric residency and pulmonary fellowship training at Children's Hospital, Colorado. He then joined the pediatric pulmonary faculty in July 2013 and is a pediatric pulmonologist for the multidisciplinary newly certified Duchenne Care Center at Children's Hospital, Colorado. His clinical interests are respiratory complications of neuromuscular disease and quality improvement in the care of children with Duchenne and other neuromuscular disorders. Dr. Finder, would you like to start?
Okay, well, welcome everybody, and nice to talk to you today. This is a talk I've given. If you've been to the PPMD meetings over the years, you might be familiar, but it's also an opportunity to ask questions, at least toward the end of the talk. I think of muscular dystrophy really as a respiratory disease, although it is clearly a muscle disease. A lot of the big problems that can end kids up in the hospital are because the respiratory muscles are involved. And we'll be focusing on the middle years today. And so I'm going to be skipping over the first decade or so of life. And in general, these are kids who are not using wheelchairs, not yet using wheelchairs. And at that point, we don't really do much besides, I like to meet them. I like to meet the families so they know who the resources are and they know who to call with concerns or questions. I say vaccinate and educate are the two major things for respiratory interventions for the normal kids. I want everyone to get a flu vaccine, for example. We start getting a more close relationship with the Duchenne patients once they start using wheelchairs, and that's usually sometime in the second decade of life. And the stages of respiratory function or respiratory dysfunction in this disease are initially you lose coughing, and we'll talk about how that can be asymptomatic. And then you'll lose the ability to breathe sufficiently when you're sleeping, and then finally losing the ability to breathe sufficiently when you're awake. And the time of when these changes, these transitions occur can vary greatly. They vary based on medication use. For example, steroids tend to slow things down. They vary based on which gene you have and other genetic factors that are called modifiers. And also acute illness can precipitate changes like a flu, which is why we always want the kids to get flu shots. So we're going to skip over the normal, so-called normal stage and go to the stage of inadequate coughing. And my point about this stage is that you're often, you don't know it, that you don't need to cough, because if you don't need to cough, you won't know that you cannot sufficiently clear your airways by coughing. The good news, though, is that it's easy to predict who does not have a sufficient amount of respiratory muscle strength to cough. And we can measure with lung function with peak flow meters or peak cough flow. You have someone cough into a peak flow meter. It's a very easy and inexpensive test to do, very quick. You can generally say who needs help. There's not a lot of data, having said this, about whether any set number is the number at which you no longer can cough adequately. And for years and years, we've used 270, less than 270 liters per minute as indication for beginning assisted coughing. I think everyone's a little bit different, and I would rather that people have help with coughing too early than too late. We know that if your cough flow is below 160, you're at very high risk for pneumonia, and this is based actually on looking at people who are trying to be extubated, and this is John Bach's work, but it's not really been reproduced. But we've sort of arbitrarily chosen 270, and people haven't argued too much about it. So we stick with that number, but I like to be honest and say it's just a number. Moving on. With helping cough, there really are two ways of doing it. And because this is a webinar, there's nothing that says every single person listening is in the United States of America. I've talked to people about this in places like South Africa and Australia and other places. And I always like to mention manually assisted coughing. So manually assisted coughing means that you basically have to help someone take a deep breath. An ambu bag, for example, or what's called glossopharyngeal. That's what that GP stands for, my slide. Glossopharyngeal breathing is also called frog breathing, where you use your lips and the cheeks of your mouth to kind of swallow air into your lungs, to push air into your lungs. And it takes about 16 gulps of air to fill your lungs. And then once a person has full lungs, then you do an abdominal thrust, or you squeeze their chest cage, a thoracic squeeze, and that forces air out. That can be somewhat effective, and it's certainly a lot better than not doing anything. So if you can't get your hands on a cough assist device, for example, we recommend this. And an ambu bag is easy to obtain and inexpensive. A lot of people with muscular dystrophy will have scoliosis, and that can limit the effectiveness of this technique. It's very common to have the chest wall muscles develop contractures. We talk a lot about contractures in muscular dystrophy, of course, in the large muscles, the knees and the contraction of those joints. But we forget that the chest wall also has muscles, and they can get contractures there as well, and you can have a stiff chest wall. Here's a picture of a nurse who is doing an abdominal thrust on a man with a spinal cord injury, and he is having manually assisted coughing. It's probably okay effective-wise, but I'm not a big fan of this. As you can see, that's probably an uncomfortable thing to go through. You certainly would not do it after lunch. You would do it before lunch, for example. So mechanically assisted coughing has become very widespread and accepted over the past decade. It's been out for it's been out for a long time. It's been out since the 50s, but the new versions came out about 20 years ago and have gained widespread acceptance. People like this therapy, mechanically assisted coughing, and it's more effective and less uncomfortable if you have a trach. So people who have trachs prefer it. It doesn't matter what interface you have, whether you use a mask, a mouthpiece, or if you have a tracheostomy or an endotracheal tube, it can be effective. And so we recommend this in the hospital, in the home, in almost any setting. It can achieve good cough flows, even in people with very severe weakness. And it is my opinion, I don't have data on this, that if you use this, if you use a device to help with coughing by the deep insufflation, that word means deeply inflating the lungs, that you can pop areas of volume loss. The word atelectasis on the slide means volume loss. There's tiny areas of collapse within the lung. You can pop the lung back open. But I also think that it stretches the chest wall muscles. You know, we talk about stretching so much, and it's so important in muscular dystrophy. But how do you stretch the intercostal, or the muscles between the ribs? And the way we do it naturally is by yawning and sighing and taking deep breaths. And I think that this device, used frequently, will probably help with your chest wall and prevent contractures in those muscles. I have in this slide photographs of some of the more common and less common devices that are now available on the market. In the upper left corner of the slide is the current version, or is the next to current version of the cough assist device. This device is produced by a company here in Western Pennsylvania called Respiratory. It used to be made by a company called Emerson, and Emerson was a long supporter of PPMD, so I'd like to mention them. This device was really just a remanufactured device from the 50s from the polio epidemic called a cough-a-lator, and then they created this thing, the cough assist device. And I like to say it's a very expensive vacuum cleaner. It's like an old-fashioned vacuum cleaner that can either pull air in or push air out. And so it has a valve and allows the air to be pushed into your lung and then pulled back out again. And those terms are insufflation and exsufflation. By the way, when I mouse, do you guys, Kathy, if you could speak, do people see the mouse over?
I don't think so. Danielle, can people see the mouse?
I don't see it right now, so no.
Well, I mean, I can use perhaps this thing here. Can you see this? If I there's a little spot there now on the screen. That's a little strange, but that'll work. So this device is called the Nippy Clearway. This one here, the Nippy Clearway, is used in Europe and frankly, they're all the same. Pushing air in and sucking it back out again. I hate to say it, but it's kind of all the same in terms of how it works. This device was over here now. This is here. I'll delete that, and I will show you. And now you can see this device here that I'm circling is the newest one on the market. That's the Hillrom Vital Cough, and it's very, very similar to the Respironics device. What I like about it, and you can see when you compare the device here to the older cough assist above it, the older one has lots of knobs on it, and those are easy to bump, and then you can sort of have to change you have to worry about the possibility of changing the settings unintentionally if when you're moving the device the knobs get bumped. And I used to have people mark the position of the knobs with a Sharpie, with a black marking pen. The Hillrom device here, shown with the green circle, that device is flat and it's electronic and it does not have any knobs to get bumped, and it works about the same. It's the original cough assist device shown in the upper left is about 20 pounds. It's not light. The Hillrom is about 15 pounds. But it works great. I've seen it. I've definitely, I would say it's every bit as effective as the other devices in the market, and it's worth knowing about. In the lower right is kind of the one that is on everyone's lips at this time. This is the new version of the Philips Respironics cough assist device, and the model shown here is called the T70. In Europe, there's one called an E70 you can get. This is a very cool device because it's tiny. It only weighs about 10 pounds, so it's half the weight of its predecessor. It's very, very easy to use. It's sort of based on how the the Respironics company makes their BiPAP devices. And it's small, and it has a very small need for energy, and so you can run it off a car battery, for example, in your car. It has an internal battery, which is kind of amazing. It has something that they call cough tract technology, and this is very exciting. The cough tract technology means that rather than just setting the knobs and saying that the typical is you set the inspiratory time, the expiratory time, and the pause time. So you'd say, I usually start with 2 seconds for each of the settings and say, well, okay, it blows air into you for 2 seconds, and then it immediately pulls the air back out again for 2 seconds, and then it pauses for 2 seconds. Well, that's fine, and that's sort of like a metronome. It just click, click, click goes ahead. That's the automatic way of doing the cough assist device. But the new version has a cough track setting, and so it will not trigger until you begin to inhale. And when the patient begins to inhale, the device senses that, and then it'll trigger a sudden flow of air into the lungs, and it'll pull it back out again. And people like that a lot because there's no surprises. And it gives the patient a sense of control over the device. And as you know, loss of control is kind of a big deal in this loss of ability to change the world around you in muscular dystrophy is a big issue. And so this is kind of a cool thing. Even if it's a tiny little thing, I think it's very cool and exciting. So I'm a big fan of this device. The problem, I will tell you right now that I'm mad about one thing, and here it is. All my patients who have been getting these cough assist devices from me for all these years now want the new cough assist device. And I cannot get it approved because the old ones work well and they're effective, and the insurance companies are not going to pay for a new one. And I have people like throwing these things off trains saying, "No, they got the guy broken." Not literally off trains, but people want the new one. And so it's a high-class problem. That it's so effective that everyone wants a new device. So pretty cool device, lightweight, small, available around the world. Again, I try not to play favorites, and that's why I'm showing all these devices out there. There's a couple others probably as well, but these are pretty important for people to know about, and they're easy to in general easy to get. Not everywhere in the world. I know in Canada they're not standard of care where they pretty much have been in America. Okay, shifting gears now. A little bit about oxygen. When someone gets sick, they go to the emergency room, and it's common that you measure a person's oxygen saturation, hemoglobin saturation. And every nurse, every physician on the planet, the knee-jerk reaction when they see that the hemoglobin saturation level is low is to reach for a can of oxygen or for the oxygen on the wall and put the person on oxygen. That seems like a reasonable thing to do. The problem is that it may not be the right thing to do for a Duchenne patient because oxygen can suppress respiratory drive. It means that you don't feel like you need to breathe as much. And we don't know whether your oxygen is low because you have a pneumonia, or is it low because you have asthma, or is it low because you have slowly been going into respiratory failure and your carbon dioxide level is high. And I always say that oxygen for a person with respiratory failure is like putting a Band-Aid over a stab wound. You temporarily cover it up, but the problem is still there and, in fact, can be made worse by it. So it's very important to check carbon dioxide level in any person who shows up with a low saturation, because if a person has a high carbon dioxide level in their blood, that means they need to be given assisted ventilation, usually with a mask ventilation. The third stage of the disease is when you don't breathe sufficiently in sleep. People who have need for help breathing in sleep can easily be predicted by a lung function test. It's interesting that there's a nice and tight correlation with the number called FVC, which stands for forced vital capacity. It is how long a person can blow out, how much air a person can blow out of their lungs. And if you're less than 30% of the predicted number, you can almost guarantee that person needs to be on breathing support during sleep. Even if the breathing is fine awake, 100% sat in room air and your carbon dioxide levels are perfect, if your FVC is 25%, I can almost guarantee you need to be on help with sleeping. The signs of not having enough breathing during sleep can be very subtle as well. Morning headaches are very common, so I always ask about that. Change in school performance, sleepiness, but quite often it's awakening frequently. I had a patient many years ago, and Daniel's mother called me up and said, "Dr. Finder, I need you to prescribe a sleeping pill for my son." And I said, "Why?" "He's waking up all night long and having these nightmares about drowning." I'm like, "Oh, my God." I said, "Well, your child needs to be put on BiPAP." And she says, "No, I just want a sleeping pill." I had to explain to this mom that, in fact, those are the classic signs of respiratory failure during sleep, and that we needed to get him onto ventilation right away as an emergency. And actually, we had him arrive into the hospital based on that symptom. And he did very well with that, but she just wanted a sleeping pill. She didn't realize that would have been a disaster for him. Obviously, sleep studies are good, but even where your sleep studies cannot be obtained, the pulse oximetry study can be done easily, and you tend to see the carbon dioxide goes up, the oxygen level goes down. A sleep study is a gold standard, but they're not available everywhere in the world. I'm mindful of that. They're not so easy to get. This is a paper, if you want a reference, that shows, this is from 1995, that if you draw a line at 30%, the majority of everyone in the study who had muscular dystrophy, this was actually both people with spinal muscular atrophy type 2 and the Duchenne patients. And you can see that people, once I have to use my little marker here. Once you see this guy here, no, it's not working, hang on. All the X's with squares around them, all these patients up here are Duchenne patients, and they needed to be put on ventilation. Whereas those who have X's without squares did not need to be in there, and that line is at 30%. So it's pretty reliable. In general, the field has changed dramatically since I started my training in 1990, and we've really gotten away from tracheostomies. We tend to use mask ventilation. BiPAP, I'm proud to say, was invented here at the University of Pittsburgh by my friend Mark Sanders. And BiPAP is a brand name of Respironics, and the ResMed version is called VPAP. But as far as I'm concerned, any positive pressure ventilation is good. I don't have a strong preference. There's AVAPs and there's IVAP and VPAP and all these crazy phrases. But my feeling is if you need some help breathing, I'm happy to use any ventilator that's out there. I'm not trying to sell one company over another. But what you do not want to have is what's called CPAP. CPAP is a constant pressure, so it does not help your lungs inflate. What CPAP does is it keeps the upper airway open, and that's fine for people with obstructive apnea, but it does not help people who do not breathe sufficiently during sleep. For these non-invasive, which means no trach, kinds of breathing supports, you need to have a very well-fitted mask, and that's really the hardest part of the job is getting a mask that fits. I always like to say it's kind of like finding a hairdresser that knows how to cut your hair right. That's essential, and so we need a really good fitting mask. Unfortunately, for older people, for people, teens and adults, there are lots of different masks out there. There's different kinds of interfaces. There's nasal masks, and there's a mask that go over your nose and mouth. There's masks that go over the entire face. There are just nasal pillows that go into your nose. There's all kinds of different setups. You can even use mouthpiece setups. And I always order a sleep study to titrate the level or to adjust the level. I don't just set it up, because if you have the wrong level, it's going to be uncomfortable and people won't use it. We tend to use what's called high span, which means the difference between the top and the bottom is a relatively large number. So high span BiPAP means that we'll do like 18/4 would be a typical setting. Finally, during the stage of needing to be on the ventilator all the time, that means these patients have carbon dioxide levels that are high even when they're awake. Back in the old days, that would be when I would recommend a tracheostomy, but it's no longer necessarily the case. We can generally manage people with non-invasive ventilation. We use a mouthpiece ventilator, and nowadays there are these lightweight ventilators that can be mounted on the back of a wheelchair, and they really are great, and they really facilitate getting out there and doing stuff, staying at school, going to work. I have some pictures here, and here's a guy who you can see his mouthpiece right there, and it's a little angled mouthpiece. You can see it here. His name is Kevin, and his dog is on his bed. But other than that, it's a good picture. And he has a ventilator in the back of his chair, and his mother was kind enough to share some pictures. Actually, these pictures from when he was a bit younger, and you can see that there's a kind of a gooseneck. You see a little gooseneck right along here, and it holds an angled mouthpiece. You can see the angled mouthpiece right next to his face, and he just takes a breath when he needs to, about once a minute or two, or once or twice a minute. And this is a much better image. You can see the angled mouthpiece here. This little gooseneck is really critical, and the angled mouthpiece right there is critical to to working. And he has been on mouthpiece ventilation for like a decade and is alive and well, and he's done very, very well. Here's another guy. His name is Matthew, and he has a different kind of arm rather than a gooseneck. It has this kind of arm. And what's nice is that the company that makes the Trilogy ventilator, which is also Respironics, they also will set up your chair and give you the gooseneck arm or to put it in place. So people have really come along. It used to be very hard to get these things set up, not so much anymore. And Matthew's parents were kind enough to share this with us. And this is Patrick, and here he has a mouthpiece ventilator graduating from law school. This was a decade ago. And I'm always proud of Patrick because he did more than anyone ever had done before with a person with muscular dystrophy, respiratory failure, and never had a trach. So that's Patrick. Let's see, I believe it should be my last slide. So to wrap it up, for every stage, there's a solution, and every solution has a non-invasive solution. And these kids do very well, and that's Oren's talk. So I'll stop there and let Dr. Kupfer take over, and I thank you very much for being here today.
Dr. Finder, thank you very much. That was a terrific talk. And there may be a little bit of overlap with some of my slides, but I think we should be able to enjoy some of the details that I'm going to share with you. First and foremost, I agree with Dr. Finder that there's a non-invasive solution to just about every problem that you can encounter in terms of respiratory issues in muscular dystrophy. Here's a quick list of topics that I want to talk about today. First, I want to talk about the management of an acute respiratory illness in the tween or early teen with Duchenne, talk about anesthesia and post-operative care, and then a quick discussion of evaluation of sleep-disordered breathing. So let's start with a quick case description. We've got an 11-year-old boy with Duchenne. He's got fever, he's got some nasal congestion, he's been coughing for 4 days. His family takes him to the emergency department where he's noted to be breathing a little bit fast and his breaths are shallow. His oxygen saturation is 90%, which is, if you live in Colorado where I am, maybe that's not so bad. And his heart rate is about 110, which has been his heart rate. So what could be going on? Well, the ED likes to think, it doesn't look that bad. Maybe it's just a viral cold, nothing more. Maybe it's pneumonia. How do we tell? And why is his oxygen low? Or in Colorado, why is it almost low? And so this is the way I think about acute respiratory illness in neuromuscular disorders. You get an acute infection, you get increased mucus production, so you cough, but you can't cough very well. And because you're using your respiratory muscles more, they get tired. And then you can't clear secretions well, so it perpetuates the cycle of impaired mucus clearance, leading to the risk of more infection, more mucus, more ineffective cough, and more muscle fatigue. And you get into this vicious cycle. As Dr. Finder said, oxygen is not the answer. I like to say it's not the entire answer. And as a pulmonologist, I think what's been beaten into me in my training is that we have to find out the reason for the oxygen to be low, not just giving oxygen to mask the problem, the Band-Aid over the stab wound. And so these are kind of my thoughts. They're basically two forces that drive breathing. One is CO2 and the other is oxygen. Oxygen is the only one that we measure readily with a pulse oximeter. But if the CO2 is chronically high, like in muscular dystrophy, especially as you age, then only oxygen will drive breathing because the brain adjusts to a high level of CO2 and says that doesn't matter anymore. If we take away the low oxygen saturations, then now the CO2 isn't driving breathing and the oxygen isn't driving breathing, and so we could see what we call hypoxic drive to breathe being eliminated, and then people could stop breathing. So if you're going to use oxygen, you have to measure CO2 levels to make sure that you're not also hypoventilating. So oxygen can be used, but it's not the entire answer. As Dr. Finder showed you, these are some of the causes of low oxygen in muscular dystrophy. atelectasis, which is collapsed airways that don't participate in airflow. You can get mucus plugging from infections that block the airways so that oxygen cannot enter the bloodstream. And then you can have hypoventilation, which is ineffective exhalation, basically where the CO2 can't get out and it displaces oxygen. So what should we do in this case? I think the first step, as Dr. Finder mentioned, was airway clearance with an augmented cough and then suction to remove the secretions from the mouth or the back of the throat. Other things have been tried or have been used, certainly in our institution: IPV or vest, chest physiotherapy, inhaled medications to break up mucus. None of these are very well studied in muscular dystrophy, and they don't address the primary problem, which is respiratory muscle weakness. Non-invasive ventilation with BiPAP or VPAP or whatever set of letters you use to describe it, but not CPAP, it is indicated, especially if the carbon dioxide level is over 45. There's always a question of, do we use antibiotics in that first couple days of illness? Maybe this really is just a viral infection. And when do we hospitalize? And those are questions that are not easily answered, certainly not answered in the literature, but the guidelines, the national guidelines that were published about a decade ago suggest that early use of antibiotics may be appropriate and that hospitalization is appropriate, certainly if you're starting non-invasive ventilation when you hadn't been doing it before, or if the care of your child is not going to be able to be achieved at home to a satisfactory degree. So I always have the conversation with the families. Do you feel comfortable? Do you think you can go home with close follow-up with me, or do you think that you should come in and at least get some sort of stability before you decide to go home? So it's a conversation I have with people. Okay, let's move on to anesthesia. Here's another case. It's a 10-year-old young man who's still able to walk, but fell out of his scooter that he uses for longer distances and broke his arm. He needs surgery, so what should the anesthesiologist know in preparation for the surgery? And I think you've seen some of this before from Dr. Schell last time. So the risks of complications from anesthesia and surgery are associated with your underlying lung function, your vital capacity, your inspiratory strength, and your expiratory strength. So that vital capacity, maximal inspiratory pressure, and peak cough flow are really the important indicators. There are also risks of specific anesthetics, and then the duration of the procedure, just like with anybody else, increases the risk. So the longer the surgery, the longer the post-surgery risks are. One of the big risks in muscular dystrophy in terms of anesthesia is malignant hyperthermia. This is a reaction to inhaled anesthetics that can be deadly. And so most inhaled anesthetics are not used in muscular dystrophy, and your anesthesiologist should be able to tell you which ones are safe and which ones are not. Muscle relaxants, such as Succinylcholine, are absolutely not allowed. These are in the class of depolarizing muscle relaxants, again, because there can be significant complications and side effects from them. Most IV anesthetics, except for the muscle relaxants, are acceptable and would be preferable to use alone. Obviously, in the case of cardiomyopathy in Duchenne, the anesthesiologist should also be aware of cardiac issues. So how do we assess risk based on lung function? Many institutions, including ours, have all muscular dystrophy patients see our high-risk preoperative anesthesia clinic so that the anesthesiologist meets the family, understands their underlying lung disease, and then can plan for safe surgery. And two, we want lung function within about 90 days of surgery to get the most up-to-date vital capacity, peak cough flow, and mean expiratory pressures. So here's a list. Basically, the lower your lung function goes, the higher risk you are for anesthesia and post-operative complications. Again, vital capacity less than 30%, as mentioned before, is a high-risk situation, less than 50%, is an increased risk. Peak cough flow, as mentioned before, under 270 liters per minute is an increased risk for complications, and under 160 is a very high risk, including difficulty with taking the breathing tube out at the end of surgery. And then the mean expiratory pressure, less than 60 centimeters of water, is an increased risk for complications. And again, these are just general guidelines. If there's a young man out there who's had previous surgeries and has had complications at higher lung functions or expiratory pressures, then I would be inclined to be much more cautious with him rather than follow just these numbers. Okay, so you're done with anesthesia. You did well with fixing the arm. Now what happens? So our policy here, and I think most of my colleagues across the country would say that once the breathing tube comes out, you should be on some sort of non-invasive ventilation. I wrote BiPAP here, but it's really any bi-level ventilation through a non-invasive mechanism. And especially if you were previously on non-invasive ventilation, even if it's just during sleep, then you should have that given to you as soon as the breathing tube comes out. And that's because of a couple of things. The dry gas from anesthesia can promote atelectasis, and so you need that extra pressure to pop that back open. You can have fluid shift, especially in big surgeries like spinal fusions, so that your lungs absorb more fluid and become stiff, and so you need even more help breathing. And then, of course, if you have post-operative pain, you need narcotics, and so that can suppress your drive to breathe or make you breathe even more shallowly than you usually do. And so BiPAP will help with that. Airway clearance is also very important, especially as you're coming off of non-invasive support, as you're waking up. And so we usually use cough assist, although some places have used IPV, which is basically a percussive or vibratory mechanism through a mouthpiece. Incentive spirometry, you'll see a lot of institutions use this. It has a limited role. This is a handheld device basically that provides positive pressure and asks you to, the technique is to inhale strongly and then maintain that inspiratory force so that your lungs are slowly stretched open. In someone with muscular dystrophy who can't take a big deep breath, obviously that may not be the best way of reinflating the lungs. And then I put this phrase, which is what I put in every one of my consultation notes to our surgeons. You have to have prudent use of narcotics to balance pain control with physician-induced hypoventilation. I don't minimize at all that there is post-operative pain. We just have to recognize the potential side effects of our pain medicines. Okay, and finally, sleep-disordered breathing. And I say sleep-disordered breathing because there's a number of different disorders within breathing that can happen in muscular dystrophy. In the first decade of life, extending up to about 14 or 15 years, obstructive sleep apnea is pretty common. In the general pediatric population, it's probably somewhere between 2 to 5%, and in muscular dystrophy, it's much more than that, as much as 10 times more than that. This could be related to weight, from obesity, from steroids. It could be that the muscles in the back of the throat, the pharynx, have low tone already, and so they collapse during sleep and obstruct airflow into the lungs. A lot of our boys have tongue pseudohypertrophy, and so that tongue can get in the way and can fall back into the mouth, especially while laying down. And then we have to remember that lung function is always a little bit lower when we lay down compared to when we sit up. And if we have obesity playing on top of that, or a tongue that prolapses into the back of the throat, that may be accentuated. And so those obstructions in series can predispose to sleep apnea. The study that demonstrated that about 30% of boys in this age range have obstructive sleep apnea also showed a poor correlation with daytime headaches, fatigue, nighttime symptoms, including snoring and perception of disturbed sleep. And so even though we ask those questions, we still have to have a high index of suspicions in the absence of symptoms. The more prominent and longer-lasting sleep-disordered breathing is hypoventilation. There is poor correlation with symptoms, but I think it's probably better than with obstructive sleep apnea. And I certainly go through all of the symptoms of nighttime arousals, snoring, mouth breathing, restlessness, sweating during sleep, and then the daytime symptoms of poor concentration, morning headaches, and changes in school performance, falling asleep on the way to school or on the way home from school or in school. So I focus a lot of my questions on subtle signs of hypoventilation. The recommendation for sleep studies is that anytime there's a presence of symptoms during the day or nighttime, regardless of age, so even if you're very young, again, there's a 30% chance of sleep apnea, of obstructive sleep apnea. And then certainly once boys are in the non-ambulatory phase, we think about hypoventilation much more and recommend a sleep study to evaluate for it. All right, so in summary, acute respiratory management is directed at improving gas exchange. That means that you have to think about why the oxygen is low, not just give oxygen because it's low. And that includes an evaluation of CO2 levels. Anesthesia risks are related both to the medications used during anesthesia induction and also the pre-existing respiratory function. Post-operative care focuses on adequate pain control while also maintaining ventilation and airway clearance to reduce the risk of pneumonias. And then sleep studies for obstructive sleep apnea and hyperventilation are indicated by symptoms, but also when our boys become non-ambulatory. And really it's whichever one of those symptoms or non-ambulatory status comes first should direct the sleep study. I think that's about all I've got. I talked a little bit fast because I was so excited. But I think we can open things up to questions.
Thank you. Those were both really excellent presentations. There's one question, Oren, if you could maybe answer about the vibrating vest. You mentioned it possibly appropriate for post-op care. Is there a role for the vibration vest in Duchenne pulmonary care?
Yeah, so a couple of different ways of thinking about it. One is the problem with airway clearance in muscular dystrophy is not being able to take a big, deep breath and not being able to cough out forcefully. The vest doesn't address that problem directly. I can certainly imagine a case where if the airway is a little bit collapsed or has atelectasis and there's mucus trapped behind that, shaking the mucus loose may be helpful, but it's not the end of the story. You have to have an assisted cough after that. I do use a lot of caution with the vest because if you just do that, you shake mucus loose, you can actually cause more airway obstruction, at least theoretically, and cause more respiratory difficulty. So I would never use it in isolation. I would always use it just before cough assist.
I'll chime in here if I may. First of all, there's no literature to support it, and so I have trouble justifying it. I have definitely used it in the setting of an acutely ill person in the hospital, exactly as Dr. Kupfer has, which is in conjunction with a cough assist device. But I do not order it for home use. One difference between a cough assist device might be about $5,000 retail. These devices are between $15,000 and $20,000. These so-called vibrating vests, and they're very, very expensive. And they're state-of-the-art for cystic fibrosis, but that's a different disease with a different set of problems and a different set of solutions. So I'm not a fan of them. I have trouble getting them for kids who don't have CF, who do have some need for it, like they have underlying airway disease. But it's a different kind of. It's for people who have impaired ciliary function, mucociliary clearance is what it's called. So I kind of stay away from them in general. Okay,
thanks. So we have a question from one of our listeners that says that she has a son that uses an LTV ventilator with a nose mask at night. And about 3 times a night, the oxygen level dips to the 80s, the alarm goes off. And then the oxygen level goes immediately back up to 98%, and he doesn't seem to be in distress at all. No other symptoms. So would you have the ventilator or oximeter checked, or would you be suspicious that there's a pulmonary issue going on?
I would have somebody, without knowing the settings of his ventilator at night, they may not be sufficient. And I would predict that every single one of those episodes, those 3 episodes, where his oxygen level dips down, is during a stage of sleep called REM, or rapid eye movement sleep. And that's the highest risk time of sleep for these patients. And so this is a person who needs to have a sleep study and a retitration. Yes, it could be something like poor mask fit, but in general, he needs to be studied. I wouldn't just say just because he doesn't have a morning headache and isn't tired. It's still what he's probably doing is going into REM sleep. His saturations drop. He has a hypoxic arousal. He wakes up, starts breathing better, and then everything turns around and he falls back asleep. But he may not be having good REM sleep, which you need to have REM sleep as part of how we sleep. So I would like him to have a sleep study.
Okay, thanks. We pulled some statistics from Duchenne Connect, and the ANs were generous enough to do that for us. And out of 658 boys who are between the ages of 10 and 17, the question was, have you ever had a lung function test? And 338 said yes. 207 said no, they had never had a lung function test. 74 said they didn't know, and 8% left as blank. So, Oren, could you maybe speak to the importance of lung function tests and how often you need to get these and what those values are used for?
Yeah, so as with most chronic disease, changes are subtle, and changes may not be appreciated by the patient or by the family. And so we need objective measures. We need to understand what's been going on with pure numbers. And so the best way to do that is with pulmonary function tests. The 3 that are best, or 4 that are best studied, are the vital capacity, or how much air you can blow out of your lungs after a full deep breath. So what is your maximal breath? And then the inspiratory and expiratory pressures, so how much force can you actually generate with your muscles? And then that cough flow, which is another measurement of how forcefully you can cough. What's your risk of not being able to move mucus? And while we recommend testing these from as early as age 5 or 6, or however young the boys can actually do the tests, we don't expect to see changes until later on. But the only way to know about these subtle changes that may not be clinically apparent is to do testing.
And so do you recommend that that's done annually, or how often?
So I would say at least twice a year at each muscle clinic visit for ambulatory boys, and then non-ambulatory probably every 6 months, if not more frequently, especially if there are respiratory issues like recurrent pneumonias or hospitalizations.
Okay.
There's also good evidence out there that shows that maximal inspiratory efforts on a daily basis can perhaps slow the decline of loss of vital capacity. It's one relatively small study in slightly older, kind of middle to late teenage years, that shows that kind of pulmonary rehab or big assisted breaths on a daily basis can slow the decline of loss of lung function.
Thanks. Jonathan, how often would you recommend that the cough assist be used preventatively by both ambulatory and non-ambulatory patients?
Well, I don't use it in ambulatory patients. That's a good point. As a rule of thumb, if you can walk, you can cough. And so I can't think of a single patient I follow who is not a full-time user of a wheelchair who needs a cough assist device. So in terms of those who I prescribe it, once I find that their lung function has dropped to the point that they need it, I tell people to use it twice a day, 5 cycles of 5 breaths. And it's not just about preserving respiratory function. It's also about stretching your intercostal muscles. And I suspect that some of the literature that Dr. Kupfer was referencing has to do with preserving the flexibility of the chest wall. And I think that part of why we lose lung function in Duchenne is that the chest wall becomes stiff because the muscles fibrose. And so I want people to use it not only to reduce airway collapse and open up the lung and get air behind mucus in case there is down there, but also to stretch the chest wall. And I think that twice a day is a reasonable thing to do. And I have had enough experience where people got sick and didn't know they were sick until they were in the hospital, and they had a cough assist device in their home. But I've changed how I feel about this thing. I really want people to use it twice every day, healthy or sick. And then when you're sick, there's no limit to how often you should use it. People say, well, how often do I schedule it when my kid's sick? And I say, well, how often do you have to cough? We don't schedule coughing. You use it as often as you need to. It's every 5 minutes. With an acute pneumonia, then that's what you have to do. But whatever, if you see the kid starts to cough, you reach for it and help them out. But when you're perfectly well, twice a day should be sufficient.
Oren, do you have anything to add?
No, I agree completely. I do think that maintaining chest wall flexibility and muscle flexibility, intercostal muscle flexibility is probably the key to preserving lung function at this stage. I also recommend using it once or twice a day. I haven't, in my experience, found too many people who do that, but we try to reinforce that recommendation, and so I start a little gently with once a day and then step it up to twice a day. There's some theories that you could also use just inspiratory force or inspiratory pressures on the cough assist to blow air in and stretch the muscles. That doesn't necessarily address all the muscles of breathing, but it may stretch the chest wall.
So I agree with that one. I think that's a great suggestion. I want to just emphasize that. What people don't like about this device is the sensation of air being sucked out of your lungs. That takes some getting used to. It's a bit uncomfortable. But I say, if you're doing great, no symptoms at all, you can set the expiratory time to 0 and just use it for deep breathing, deep insufflations. And that's perfectly fine. So you can just have a pause time of 2 and an inspiratory time of 2 and an expiratory time of 0. And I think that's just as effective for stretching the chest wall. I think that's a good piece of advice, because also it also helps some kids get used to the device so they don't feel like it's a noxious and negative experience.
And it feels a little bit more like a BiPAP, just inspiratory pressure. The nice thing about the Respironics T70, not that I support using that specific device over any others, but it does have 3 presets, so you don't have to change things back and forth between inspiratory and expiratory and all these things. So oftentimes what we do is have your well settings at preset number 1. You just get inspiratory pressures, and your expiratory time is 0, so you have no sucking out. And then when you're sick, you just toggle over to preset number 2, and you get in and out pressures. So it's an easy device to use. So that's a nice feature of it.
Okay, that sounds good. And there was some discussion on the first webinar about using the cough assist for breath stacking in ambulatory patients as well. So it's a nice segue to meld both of these webinars. There's one more question. So if you have a 16-year-old boy who does not have a cough assist and a BiPAP, would you recommend those? Or it sounds like maybe a respiratory or pulmonary assessment is needed.
Yeah, you cannot assume based on age what a person's lung function is. So there's so many factors. Has he been Has he been on systemic steroids for years, and is he ambulatory, for example? There are some 16-year-olds who are still walking, for example. So the short answer is he needs lung function testing before we make any decisions. BiPAP by itself, you can't make a decision without a really good sleep study, although you can have a really strong assessment with just PFTs. But you certainly have to have him seen, and you have to have a lung function test. And that's why it's important to know a good pulmonologist in your community.
Okay, I think that's all of the questions that we have. We're just a little bit early, but I want to thank Dr. Fender and Dr. Kupfer for this really excellent information. It's been a great webinar, and I really appreciate your time and your participation.
It's been my pleasure.
My pleasure, too. Thank you.